So I will start today with lesson 2, which is genetics in male infertility, diagnosis and treatment. I thank you very much for the opportunity to develop this program. We had the first lesson 2 weeks ago, and now we are moving to the second one. Today, I would like to share with you some information about genetics in male infertility, which is quite important for all of us working in this field. The primary objective is genetic evaluation. When and to whom we need to offer this type of evaluation. The secondary objective will be to review with you genetic basis of male infertility, the most common genetic cause of male infertility, and also some genetic related sperm defects. So let's start with some basic review about genetics in male infertility. So the first thing we need to remember is that obviously the human genome, we have 23 pairs of nucleochromosomes and 22 pairs of autosomes and 1 pair of sex chromosomes. So the somatic cells, so the non-reproductive cells, they are diploid. We have 46 chromosomes. These are the basic units in organs and tissues. By contrast, germ cells, we are talking about oocytes and sperm. They are haploid, as you know. These cells have 23 chromosomes, and only the ovaries and the testes have this type of cell. Well, the chromosomes that you can see in the picture, they are composed of chromatin. What is chromatin? Chromatin is a complex and unbroken, long, double-stranded and tightly wound DNA. The chromatin is very important because the chromatin carries genes and proteins, and then it helps in packing the chromosomes in the nucleus. This is basic information we need to know. How about genes? Well, the genes are inside the chromatin. So the genes are stretches of the DNA sequence. They encode specific functions. So as you can see in the picture, there is a synthesis of proteins through messenger RNA transcription. And then we have synthesis of functional RNA. So these coding regions, we call these coding regions exons. They are interrupted by at least one or several non-coding segments that we call introns. So after actually transcription, and we have the primary RNA, and then we have the splicing, which is extremely important because the splicing process will remove introns, and then we'll make the messenger RNA containing the coding regions that will be important for synthesis of specific proteins that a particular gene is actually producing. What we say when we call locus, this is the exact site or position of a particular gene on a chromosome, and the allele is variant form of a gene. So if we have two similar alleles, we say that the gene is in homozygosis, and if we have different alleles, then we say that the gene is in heterozygosis. So in terms of spermatogenesis, we know today that there are more than 2,000 genes essential for spermatogenesis. They are actually, most of them are located in autosomal chromosomes. But we have very important genes located in the long arm of the Y chromosome. And we know today that there are about 30 genes in the Y chromosome, the long arm of the Y chromosome. Most specifically, these genes are located in a region called AZF. AZF means azoospermia factor, containing the most important genes for the spermatogenesis. Well, we will go through the Y chromosome most importantly in the next lesson, but I will also discuss the Y chromosome today. But what I want to emphasize is that the genetic background obviously is important, but also the external factors will interact with the genetic background to determine the fertility status. For instance, I can have a patient with very good genetic background, but because of external factors, exposure for gonadotoxins, varicocele, some infection, etc., mumps or caries, well, this interaction will make the individual less fertile according to the genetic background. So if the genetic background was very good, the baseline sperm count was very high, then obviously the influence of the external factor might be, let's say, not so severe as compared to an individual in which I had as a poor genetic background, meaning that the sperm count was not so high, and then the external factors will make a more important impact. So this is why some patients, they come to us and say, well, I don't know what's the problem with me, because although I smoke heavily, I have several friends who have many children. Well, this is because the genetic background of these different subjects differ in the sense that the external factor will have a different impact according to the genetic background. So when we say that the genotype is the genetic code that controls physical and performance traits. This cannot be changed by environmental factors. However, the phenotype, this is the discernible characteristic of an individual, you know, the specific external feature, biochemical, physiological properties, or even behavior. This is the expression of the genotype, but the phenotype is actually influenced by environmental factors. So there is this genotype-phenotype correlation that will determine, in this case, fertility. So why we need to investigate the genetic condition of a patient coming to us for seeking fertility? First of all, we know that up to 30% of male infertility cases have genetic origin. Secondly, it's important for prognosis because the biological fatherhood is possible for, let's say, several men with genetic related infertility, but not for all. And during this talk, you will know which cases will have a good prognosis or poor prognosis related to having a biological offspring. And the other thing that is important for the investigation standpoint is counseling, because there's risk of transmitting parental defect to offspring, and you need to know which conditions actually relate to increased risk. One important thing for all of us to actually understand is that we have two types of genetic related male infertility conditions. In the left, as you can see here, we have abnormal genotype in somatic cells. So it means that all cells in the individual, they have a problem. So by contrast, we can have a condition in the genotype is normal in somatic cells, and the problem will just be there in sperm themselves. So this is completely different situation. For instance, in the left panel, we can see that abnormal genotype in somatic cells could be like chromosomal abnormalities like aneuploidy, translocations. For instance, Klinefelter syndrome. We have 47XXY. This is a classic example of a chromosomal abnormality that will affect fertility. There are other less common, but Klinefelter syndrome is a very good example. So I mean, in all cells of a patient with Klinefelter syndrome, somatic cells, the genotype will be 47XXY. That could be mosaic or non-mosaic, but I mean, this is the basic genotype of the individual. The monogenic and polygenic gene mutations. Again, these are abnormal genotype because all somatic cells will have this characteristic. For instance, we have the mutations affecting the cystic fibrosis gene, CFTR mutations, that will cause congenital bilateral absence of the vas deferens. We have mutations in the cat sperm gene that will affect motility, sperm function, the androgen receptor gene, which is also important for some infertility conditions. We can have polygenic mutations in the CAL1 gene, which will cause Kalman syndrome, hypogonadotropic hypogonadism, and so on, including globosospermia, which is a condition related to gene mutations. And in this category that I'm explaining to you now, we also have deletions. And the classic example is microdeletions affecting the long arm of the Y chromosome that will cause infertility. On the other hand, we can have a normal genotype, but sperm with abnormalities. It could be sperm chromosomal abnormalities. We are talking about aneuploidy. We can discuss about sperm DNA damage, sperm DNA fragmentation, if you like. We also have sperm mitochondrial defects, and also epigenetic abnormalities affecting sperm that will cause some conditions, actually, that will affect the health of the subject, but also related to fertility. Let's start with the conditions affecting the in which the genotype is abnormal in all somatic cells. These conditions, including the Klinefelter syndrome, Y chromosome microdeletions, and the congenital bilateral absence of vas deferens, as you can see, could make up to 15% of the infertility cases. This is according to the data from our center, which is a referral center for male infertility. And obviously, we need to understand that being a referral center, the incidence of these conditions are higher due to the nature of our center. So when we go for, in the right panel, when we think about only patients with azoospermia, and then you see that these three conditions could make a significant proportion of patients actually with azoospermia, so explaining several of the scenarios we see related to azoospermia. So let's start with the Klinefelter syndrome, which I'm sure you have seen patients like that. The prevalence is listed there, 1 in every 600 to 1 in every 1,000 male infants. So 5% of these men will have severe oligosospermia. They have, let's say, less than 1 million sperm per ml. And patients with severe oligosospermia, usually they are mosaic. They have in their genotype cells which are 47XXY and cells which are 46XY, normal cells and abnormal cells. The classic karyotype, the classic Klinefelter syndrome is 47XXY in all cells. And this will be the patients that we see with non-obstructive azoospermia. So, I mean, this is more prevalent, having the classic karyotype in Klinefelter syndrome patients. Not always you see the classic phenotype that you see in the textbooks. We can have a normal person in front of us for the consultation, but there are some characteristics that will be actually suggestive of Klinefelter syndrome, including presence of hypotrophic testes. Usually the testes are lower than 10 cc in size. We may find gynecomastia in 1/3 of cases. Usually the FSH levels are higher than 15, and the testosterone will be low, less than 300 nanograms per deciliter. Well, this is because the testicles are small, and then the pituitary will release more FSH. And because the testicle actually is insufficient, both in spermatogenesis and androgen production, we will have low testosterone levels. As I said before, most of these patients will have azoospermia, but we have some patients, especially the mosaic Klinefelter syndrome men, with a severe oligozoospermia. So the other condition that we need to think when we see a patient with azoospermia is related to gene mutations. This is the congenital bilateral absence of the vas deferences, which affect up to 6% of men with obstructive azoospermia. Because in this case, the gene mutation will actually affect the development of the vas deferences and part of the epididymis, and also part of the seminal vesicles, because they share the common origin. So mutations in the cystic fibrosis gene actually are plenty. More than 1,500 mutations have been described, and not all ethnic groups will have the same mutations, which means that, for instance, I can have a Brazilian population of CBAVD patients with mutations affecting, let's say, the R117H, and then perhaps you have the Indian population with, let's say, more the Delta 508. So, I mean, not necessarily the populations will have the same set of mutations. So this is important because when we test for the CFTR gene, because of this huge number of mutations described so far, it's quite hard to test for all mutations. And we need to develop a panel that will, let's say, catch most of the mutations for that specific population. The clinical features of this patient with CBAVD, they have obstructive azoospermia. So the problem is not actually sperm production, like in Klinefelter syndrome men. The case of CBAVD, sperm production is completely normal. The issue is how sperm is getting out is the issue, because the vas deferens are not there. So these patients usually, they have hypospermia, I mean, ejaculate volume of less than 1.5 ml. Usually the pH, semen pH, is acid. Why? Well, because usually in patients with CBAVD, the seminal vesicles are either hypotrophic or absent. And as you know well, 70% of semen volume comes from the seminal vesicle. And the seminal vesicles are also responsible for actually neutralizing the acidity of semen. So when the semen is, let's say, with pH above 7.2, usually it means that the fluid coming from the seminal vesicles are quite okay. But when we have a problem with the seminal vesicles, in this case, we have a hypotrophy or even absence of the seminal vesicles, and then we will have low volume and low pH. So when you see a patient in front of you, just before doing the examination, that the patient is coming with the semen analysis report of azoospermia, you have low volume, you have low pH, you need to suspect of CBAVD, and then you go for the physical examination to confirm that the vas deferens are not there. And then you can do the transrectal ultrasound, if you like. It's not mandatory, but the transrectal ultrasound might confirm the seminal vesicles are either absent or hypertrophic. So these are some issues related to CBAVD. But these patients, because the testicles are normal in size and in function, they have normal endocrine profile. when we do the physical examination, we feel that the epididymis are enlarged, but in some patients, we only feel part of the epididymis, only the epididymis head, the cranial part of the epididymis. Obviously, the vas are non-palpable, and the seminal vesicles could be either hypoplasic or not present. So this condition is a mutation affecting the long arm of chromosome number 7. So as you can see in the picture, this is like the map of the chromosome number 7, and we might have a mutation affecting, let's say, a very, let's say, large portion of this gene, and according to the type of mutations, we will have different phenotypes. And the third one that is very important for us to discuss is the Y chromosome microdeletion. The prevalence is like there, 1 every 1,000, 1 every 3,000 male infants, and it could affect up to 12% of infertile males. Well, these mutations are not inherited by the offspring. Actually, these are de novo mutations. This is the first time in a generation that the mutation might occur. There's a lot of speculations how these mutations could come from, including hypotheses that it could come from DNA fragmentation, in which very, let's say, double strand break affecting the Y chromosome could actually result in losing parts of this chromosome that will contain the important genes for spermatogenesis. So the patients with Y chromosome microdeletion, usually they have hypertrophic testes, but not always. In certain situations in which we have maturation arrest, the testicles could be normal, and the patient still, he will be azoospermic, and because of Y chromosome microdeletion. So usually the patients will have azoospermia, but some patients might have severe oligozoospermia. The FSH levels will be either elevated or normal, and in some conditions, a varicocele could be found, or history of cryptorchidism. These conditions might coexist with Y chromosome microdeletion. So when you see a patient with azoospermia, varicocele, and then you should not say, okay, I believe this azoospermia is caused by varicocele. Varicocele could be just coincident, and you need to test for Y chromosome microdeletion gene mutations to see if something is there that could explain infertility. So as you see in the picture, in the long arm of the Y chromosome, we have 3 important AZF regions. We have AZFA, in which we will find some important genes, AZFB, which is larger, with more genes, and then AZFC. This is actually the 3 most important regions we'll be discussing later on during this talk. What is important for you to know is that the frequency of chromosomal abnormalities and Y chromosome microdeletion will be according to sperm count. So let's say it's very unlikely that we will have any chromosomal abnormality or Y chromosome microdeletion in patients with, let's say, more than 15 to 20 million sperm per ml. Very rarely we find something in, let's say, patients within normal range. Perhaps we will find a translocation, but not Y chromosome microdeletion. We won't be able to find a Klinefelter syndrome patient having more than 5 million ml sperm per ml. So the lower the sperm count, and the lower meaning approaching 0 azoospermia, the higher the frequency of chromosomal abnormalities and Y chromosome microdeletions. So when to investigate? Well, it's like the tip of iceberg. Because if I have a patient with oligosospermia, less than 5 million per ml, or azoospermia, you need to suspect that behind that phenotype, possible genetic cause. So you need to think about possibility of genetic conditions affecting male fertility in patients in which you see a semen analysis report showing oligosospermia or azoospermia. In the first lesson, 2 weeks ago, we discussed about indications for genetic testings in male infertility, and I presented this table to you, in which we have the recommended tests according to the condition. For instance, we have men with infertility and the sperm count is below 10 million per ml. These patients are candidates for ART. And then there's a recommendation for doing Y chromosome microdeletion testing and the G-band karyotyping. If I have a patient with non-obstructive azoospermia, because you have made the diagnosis based on the testicular size, the endocrine profile, the history, and then you need to kind of discuss the possibility of the patient being with Y chromosome microdeletion or Klinefelter syndrome. Then you need to test for Y chromosome microdeletion, the karyotype. So when you have a azoospermic patient and less likely a severe oligosospermic patient with the absence of at least one vas deferens at physical examination, you need to suspect of a mutation affecting the cystic fibrosis gene. And then you need to ask for this CFTR gene mutation, the same if the patient has completely azoospermia, and in the physical examination, you feel that the testicle is normal, the FSH is normal, the testosterone levels normal, and then you have the low semen volume and low pH. In that case, you need to suspect and confirm by physical examination the absence of the vas, and then we need to test for CFTR gene mutation. And if you have a history of recurrent miscarriage or personal familiar history of genetic syndromes, it's wise to go for the G-band karyotyping. So I think this table could provide you guidance when to test for genetic panel in male infertility. So it's very easy to test because actually genetic analysis is quite widespread in infertility centers. Some infertility centers are running the tests themselves. Other centers are referring to a genetic clinic. In our case at Androfert, we are not running the tests in-house. Actually, we have a partnership with a genetic laboratory in which we take the blood. All the testing can be done with peripheral blood, and then we do the testing according to the type of analysis we are looking for. For instance, if I'm planning to do a Y chromosome microdeletion testing, I will go for the multiplex PCR to map the three regions of the Y chromosome that could be present or absent, and the markers that they will analyze actually will represent the areas of the AZFA, AZFB, and AZFC. In a case here, for instance, the patient has the presence, the AZFA is present, but AZFB plus C completely absent. This is a very, let's say, severe condition that will have prognosis information. I will discuss that in a minute. Here you see an example of the G-band karyotype in the patient with Klinefelter syndrome. We have 2 X chromosomes and 1 Y chromosome. This is a typical report you see from a patient with Klinefelter syndrome. For the CBAVD, for the genetic mutations affecting the cystic fibrosis gene, usually it's PCR plus gene sequencing to look at that long area in the chromosome 7 that could actually harbor the mutations affecting actually the possibility of the full development of the vas deferens, the seminal vesicles, and the epididymis. So they will report like that. Well, when we go for the Y chromosome microdeletion screening, it's important that, for instance, if you use different laboratories, it's important that they communicate the same way, they report the same way. According to the European Association of Andrology, in which they have published guidelines for molecular diagnosis of Y chromosome microdeletions. So the report must include at least these primers that I presented in this figure. For instance, for the AZFA subregion, at least you should see SY84, SY86. For AZFB, at least SY127 and SY134. And to map AZFC region, you need to see SY254 and SY255. What I'm trying to say is that next time you get a report, and their report is not actually including these 6 primers, well, something is wrong, because they are not mapping the Y chromosome according to the best practice guidelines. So perhaps the patient will report as normal, but in fact, microdeletion could be there if the clinic, the laboratory, have carried out the analysis as recommended by these guidelines. So if in your network, in your clinics, you use the same laboratory, well, fine, because then you can communicate with them and say, listen, are you actually giving us the report according to the European Association of Andrology guidelines, in which you are including this, at least these 6 regions? Well, if they say yes, and then we are in good shape, because you are actually doing the evaluation as actually recommended. So just have a look in the reports you get and make sure that these primers are there, because then you know that the report and the analysis is done in the proper way. If not, you need to discuss with the laboratory providing you the genetic analysis for Y chromosome microdeletion to include these primers that will represent better the genes, because they will actually map better the genes, the important genes for spermatogenesis, which are located in the long arm of the Y chromosome, specifically in these 3 regions, AZFA, B, and C. Well, having said that, how we interpret results? Well, it's very important to understand that when we have abnormal result for the karyotype, for the Y chromosome microdeletion, or for this cystic fibrosis gene mutations, then we can establish that there's a genetic factor actually explaining infertility. Also, we can have prognostic treatment information. For instance, in patients with azoospermia, according to the results of Y chromosome microdeletion, we might actually discuss the likelihood of finding sperm, or even if the patient is a candidate for sperm retrieval. And also, according to the genetic factor, it might affect the outcome of IVF and ICSI. The third important point concerning test results relates to genetic counseling, because then we need to discuss the risk of infertility transmission, risks of malformation, disease, and miscarriage, and discuss the role of PGT for patients undergoing IVF and ICSI. So let's go through, because I will discuss these conditions now when we discuss the clinical management of genetic-related male infertility conditions with abnormal genotype in somatic cells. So now let's consider Klinefelter syndrome. You have now the patient in which you have made the diagnosis, because the patient came with semen analysis report showing azoospermia, FSH was high, testicle size was small, testosterone levels low. You have ordered the karyotype, and the karyotype actually confirmed Klinefelter syndrome. Well, these patients, they might have areas of sperm production. It has been described that 40 to up to 50% of patients with Klinefelter syndrome, most likely the ones with mosaic karyotype, these are the patients more likely to have residual sperm production within the seminiferous tubules. We can find 8% of the seminiferous tubules, up to 25%, with, let's say, complete spermatogenesis. The testicular histology, if you actually look at the testicular histology, I'm not recommending you do that because these testicles are very small and we need to save the testicle for sperm retrieval. But the testicular histopathology will show Sertoli cell only as a predominant pattern and tubular hyalinization. But we may find focal areas of spermatogenesis as this one presented here. Well, in terms of sperm retrieval, and if you go for the open biopsy, without the microscope, the success rate will vary overall. I'm not talking about Klinefelter syndrome only. I'm talking about all patients with non-obstructive azoospermia, between 20 to 63%. But in Klinefelter syndrome patients, it will be very low success rate if you just go for, let's say, a single or multiple biopsy. The best results are achieved with micro-TISI. In this case, we might have, let's say, 40%, up to 40% success rate in Klinefelter syndrome patients. These patients, they will have only one chance because the testicles are so small that when you open the testicle, actually, you need to kind of look for the seminiferous tubules, which are more enlarged because they will be more likely to have sperm production. I will go through the sperm retrieval methods in the next lesson next week. So I will save some of the information for the next presentation. But today, it's important for you to know that Klinefelter syndrome patients, they might have sperm. And the best method, if you have the option to offer these patients the microsurgical sperm retrieval, that will be the best, let's say, chance for these patients to have sperm. Well, usually what I do with my patients with Klinefelter syndrome, I try to boost testosterone production to increase the chance of sperm retrieval. There has been some reports suggesting that when we actually increase testosterone production, and then you can use HCG therapy, you can give anti-estrogens like clomiphene citrate, tamoxifen, aromatase inhibitor, and then these are the medications that you can play with. My preference is HCG. I will discuss more next week. So I like to prime these patients with some medication for 2 to 3 months, at least 2 to 3 months, before I go for sperm retrieval, because it has been shown that the sperm retrieval success rate will be increased in patients who respond to medical therapy, especially when the increase in total testosterone levels is like more than 100 nanograms per deciliter from baseline levels. For instance, if the baseline level of the patient is 150, and after medical therapy, the testosterone goes to 300, well, these patients will have, theoretically, a higher chance of having sperm found on sperm retrieval. So if we succeed to find sperm in a Klinefelter syndrome patient, what kind of sperm we might have? Well, we can have normal sperm like this, 23Y. We can have 23X, but we can also have abnormal sperm, 24XY, 24XX. Well, then we need to discuss with the patient if the couple would like to undergo embryo biopsy in order to identify, for instance, offspring who will be Klinefelter syndrome patient, or to avoid miscarriage, because if it's triple X most likely this will result in miscarriage. So the options would be to go for PGTA with a day 3 biopsy or NGS day 5 biopsy, which is our preference in this scenario. However, it's important to recognize that even though the biopsy, the PGT, has been recommended for patients with Klinefelter syndrome undergoing ART, there are many reports in the literature suggesting that the offspring of couples whose male partner has Klinefelter syndrome, the offspring is normal. So it questions the suggestion that we need to recommend PGTA as mandatory for all couples undergoing IVF and ICSI. So what I'm trying to say that we need to discuss with the patient if there's a possibility to undergo PGTA and the patient can afford it. Well, it's okay. I think it will avoid having an offspring with Klinefelter syndrome. We will avoid miscarriage due to the triple X genotype. But according to the reports, and we have several patients here at Untitled in which we haven't done the genetic analysis, and these patients have normal offspring. So I believe the counseling is important for this patient population. For CBAVD is a completely different scenario because patients with CBAVD, they have obstructive azoospermia. The problem is absence of the VAS, but the testicular histology is normal. These patients have normal spermatogenesis. And as you can see in this right graph from a paper we published in which we look at sperm retrieval success rate according to different phenotypes. We have CBAVD, we have post-vasectomy and post-infection. All these categories of obstructive azoospermic patients. So the likelihood of finding sperm using percutaneous aspiration could be percutaneous epididymal sperm aspiration or testicular sperm aspiration is 100% in patients with CBAVD, just stressing the fact that these patients have normal spermatogenesis. So in our clinic, what we do, we like to do the percutaneous epididymal sperm aspiration for patients with CBAVD because it's quite easy to actually collect sperm with the tuberculin syringe and the insulin needle. We just actually provide some local anesthesia. Usually, I like to give the patient some propofol, so intravenous sedation with propofol. We do it as outpatient basis. So the procedure is quite easy. You just need to grab the testicle firmly, actually identify the epididymis. So in this case, I'm holding the head of the epididymis and using the syringe and needle, actually, I'm puncturing the epididymis. I do some squeezing to make it easy to extract the epididymis fluid. And then we examine the IVF lab. So if you want to see the video is presented on top of the screen. We have the video actually in this link. It's also in YouTube. And then actually it's presenting the steps that we need to go through after aspirating the fluid from the epididymis and then preparing for ICSI or cryopreservation. We can do both. You can plan the case in which you collect sperm and freeze and do ICSI subsequently later on, or you can do fresh. In this case, we can do the way we like because sperm survival after the freezing and thawing procedure is quite good. These patients, they have obstructive azoospermia. And also because the chance of finding sperm is 100%. So you can plan the cycle concomitantly with the egg retrieval because you know that you'll be able to find the sperm in all cases. So this is a very, let's say, convenient scenario. Well, we have done the study that I presented before. We look at reproductive potential of men with obstructive azoospermia undergoing percutaneous sperm retrieval. In this case, we did either percutaneous epididymal sperm aspiration, and in case we fail at the same time, the same operative time, we moved from PESA to TESA, in which, I mean, if I don't collect enough sperm for ICSI using the percutaneous epididymal sperm aspiration, I just move to the testicle and do the testicular sperm aspiration. As you can see in the CBAVD scenario, it's 100%. Most patients will have sperm by percutaneous epididymal sperm aspiration. Some patients might need the testicular sperm aspiration, but the results are very good. Well, the other thing that actually, in terms of the fertilization rate, it's compatible with other categories of obstructive azoospermia like vasectomy and infection, and number of embryos. The proportion of high quality embryos is quite good. The clinical pregnancy is about 50%. And miscarriage, as you can see here, 25% in our cohort, and then 35% live birth per attempt, per transfer, in cases of CBAVD, which is quite compatible with vasectomy and post-infection. So obviously, these live birth results are influenced by the female age, but in our patient population, in which the female age is above 36, 37 years old, it's good, let's say, results we have been achieving with these genetic conditions. Here you can see that in terms of the neonatal profile of the resulting offspring, they are quite compatible as well with other categories of obstructive azoospermia in terms of the gestational age in weeks, and also the birth weight of the babies born. They are actually very good. In this series, we had only one stillborn and no malformations in patients in which we treated with ICSI, and the male partner had CBAVD. So CBAVD is good because we can do sperm retrieval and ICSI. We need to consult the patients about the genetic risks to offspring. In this case, it's important because if I have a couple in which the female is also, let's say, carrier of CFTR mutations, and then the offspring can have either CBAVD, 25 to 50% if mutations is there in the female partner. And if there's no mutation at all detected in the female, there's still risk of 0.4% because the gene is too long, and sometimes we might miss a mutation if the panel is not comprehensive. So what is important to know is that CBAVD is, let's say, a very mild, let's say, presentation of a problem affecting the cystic fibrosis gene. Because if the mutation is severe and it's affecting both father and mother, and then transmitting that big mutation to the offspring, the baby could have autosomal recessive little disease, which is the cystic fibrosis. So this is why it's important, in my opinion, it's mandatory to test the female, because when I have this patient in front of me, the male patient, in which I made the diagnosis of bilateral absence of the vas deferens, azoospermia, low semen volume, low pH, I know that this patient will have a mutation somewhere in the cystic fibrosis gene. So my first approach to save money is to kind of not testing the male, because I know the male has the mutation somewhere. I will go ahead and test only the female partner, because by testing the female partner, if she's abnormal, if she has the mutation, well, then I need to go back, test the male to kind of plan the treatment, because then I will need to do PGT-M, because then pre-implantation genetic testing for monogenic disease, or I will need to plan for sex selection to avoid the male offspring. But for the sex selection, I will not be able to avoid the cystic fibrosis if the female partner is a carrier of the mutation. So this is why, for me, it's very important to test the female. If the female is normal, I will say to my patient, well, perhaps we could not identify a very rare mutation, but the risk for cystic fibrosis is very, very low. So we can go ahead with ICSI if the couple is actually satisfied with that counseling. However, if the female partner has a mutation, in that case, I will test the male, I will map what kind of mutations I have in the male partner, in the female partner, and then I will go ahead and do PGTM with gene sequencing of these embryos to detect which ones are affected by cystic fibrosis. Obviously, we won't be able to transfer them back. So for the pre-implantation genetic testing, the CBAVD, we can have the PGTM, in which we can do day 3 or trophectoderm biopsy. In our conditions, we use a genetic laboratory in which we do SNP microarray for these conditions. If the mutation is in the spouse, as I said, we can avoid cystic fibrosis. If the mutation is in husband, we can avoid CBAVD in the baby boy. So we can also explore the possibility of doing PGT for gender selection. In that case, we can do cleavage stage embryo biopsy or blastocyst trophectoderm biopsy. This is only when there's no mutation in the spouse, and our, let's say, approach would be to avoid CBAVD in the male offspring. In that case, you might consider using the PGT for gender selection. Let's now move to the next condition, which is Y chromosome microdeletion. As I explained to you, these patients will have non-obstructive azoospermia, most likely, and in some cases, severe oligozoospermia. Why is it important to test? Well, because the chance of finding sperm on sperm retrieval will actually depend on type of deletion. So you test, you do the PCR for the AZF region of the Y chromosome. If the report says microdeletion affecting the AZFA, well, this patient is not a candidate for sperm retrieval because the genes actually in AZFA are so critical for spermatogenesis that absence of these genes will imply automatically that the patient will have no chance at all, regardless of the technique you use for sperm retrieval, to have sperm for ICSI. So you need to exclude the possibility of doing intervention in patients with AZFA microdeletion. The same applies to AZFB with some exceptions, because the AZFB is large, let's say, region with many genes. So it has been described that patients with partial, let's say, deletions affecting the AZFB region could eventually have sperm found. So we have 2 couples in our clinic in which we found sperm in a man with AZFB partial deletions. So then we need to explore that panel in a different way. We need to use more primers. And then when I have a microdeletion affecting a patient of mine saying AZFB, I go for the geneticist and I will discuss with him to increase the size of the diagnostic panel, the PCR, to see if the deletion is complete or if the deletion is partial. If it's partial, I will discuss with my patient that there is a possibility of doing microTZ and finding sperm in about, let's say, maximum 20% success rate. So if the patient is okay with that, and then I go ahead and do the microTZ. So the best scenario would be to have a patient without any deletion, of course, or with a deletion affecting AZFc only. So when the deletion only affects the AZFc region, there's 50% success rate in finding sperm. So as you can see, testing is important for providing prognosis in terms of sperm retrieval for patients with microdeletion. In patients with AZFc microdeletion in the Y chromosome, they have either, as I said, severe oligozoospermia or non-obstructive azoospermia. Among patients with non-obstructive azoospermia, the testicular histopathology will be hypospermatogenesis, maturation arrest of Sertoli cell only. So you can find sperm in about 50% of cases, especially if you apply the microdissection testicular sperm extraction. So this is the technique that I will discuss next week that will provide the higher chance of finding sperm in men with AZFc microdeletion. This is the way we do. We do in our clinic. We have our operating theater, which is just next door. We have the IVF laboratory, and I do the operation with a microscope, and I provide the specimens to the laboratory to look at, and then we have better results in our hands with microTZ in cases of non-obstructive azoospermia, including AZFc Y chromosome microdeletion, in all histopathology categories. So as you can see, very high success rate in hypospermatogenesis, 64% in maturation arrest, and 20% in Sertoli cell only. Even in the worst case scenario, we can still find sperm in the testicle in patients with non-obstructive azoospermia using the operative microscopy. So for these patients, for AZFc, because I told you AZFA and B, they are, let's say, not candidates, but AZFc, I can apply the sperm retrieval method. If I find sperm, then I need to counsel the patient, the couple, about genetic risks to offspring. First of all, it's important to tell the couple that if it's a baby boy, the Y chromosome microdeletion from the father will be invariably transmitted to male offspring, which means the baby boy, when adult, he will be infertile. There's 100% chance of transmitting the deletion from the father. Sometimes the deletion in the offspring could be even bigger than the father and could affect some other conditions. But what we need to say to the couple is that, well, we have found sperm. Now we are doing ICSI. And then you have the option of doing ICSI without PGT for sex selection or doing PGT for sex selection, because then you can avoid, let's say, the baby boy with the Y chromosome microdeletion. The other important thing is that some patients with severe oligozoospermia harboring AZFc Y chromosome microdeletion, they might have a temporal decline in sperm production. For instance, I have seen some patients, young adults, having AZFc Y chromosome microdeletion, in which the sperm count is like very low, less than 1 million per ml. So if you find a patient like that, and you test for Y chromosome microdeletion screening, and you discover that the patient's AZFc Y chromosome microdeletion, you should start sperm freezing immediately to bank sperm, because in future, few years later, it could be that this patient will not have any sperm left for cryopreservation, and then you will need to rely on sperm retrieval. To avoid that, there's a possibility of actually doing sperm freezing. So here I would like to present some results of sperm retrieval success and ICSI outcomes in genetically related azoospermia. In purple, you see Y chromosome microdeletion screening and Klinefelter syndrome together. And you see that the sperm retrieval success rate is about 40%. And in pink, you see sperm retrieval success rate with CBAVD 100%, as I told you before. When we go for the laboratory and ICSI, it's quite remarkable to see that the results overall are better in case of CBAVD, because these patients have obstructive azoospermia. This is a good condition in terms of having fertilization, embryo quality, clinical pregnancy, and live birth. And it's actually results are better for CBAVD as compared to Y chromosome microdeletion and Klinefelter syndrome patients. But in terms of the gestational outcome of babies born, well, these are quite similar. We don't see, at least in this cohort of patients we published some years ago, no difference in terms of the offspring, birth weight, the perinatal death or malformation rate in this patient population. So for this part, I would like to conclude that male fertility is genetically determined because we have more than 2,000 genes involved in spermatogenesis. Genetic defects are implicated in about 15% of male infertility cases, up to 30% among men with oligozoospermia and azoospermia. So you need to suspect of a genetic condition when you find patients with oligozoospermia, in particular those with less than 5 million per ml, and azoospermia. The three most common conditions are Klinefelter syndrome, CBAVD, and Y chromosome microdeletions. So it's very easy today to make the diagnosis because we have both the cytogenetic and molecular-based testing, and testing results will be extremely useful for diagnosis, counseling, and treatment planning. So please do genetic testing to your patients with oligozoospermia and azoospermia. And the treatment options will involve ART with or without PGT. Now, I want to dedicate some minutes of my talk to the second aspect of genetic-related male infertility, which are the patients in which the genotype is completely normal in somatic cells. So there's nothing wrong. The problem will only actually affect sperm. And then we can have, as I said before, sperm chromosome abnormalities, sperm DNA damage, mitochondrial defects, and epigenetic abnormalities. So in this condition, if you have a patient with recurrent miscarriage, absolute teratozoospermia, or 100% abnormal results after one or more cycles of PGTA, you might actually consider doing FISH analysis for sperm. In that case, FISH will be a cytogenetic assessment of any meiotic defects that will quantify aneuploidy rate. So you see that, for instance, there's an increased risk of, let's say, having this miscarriage or abnormal PGTA results in patients with, let's say, high aneuploidy rate affecting sperm. I myself rarely actually apply FISH technology to sperm because the proportion of affected sperm will be around 1%, 1.5%, up to 3% only in patients with, let's say, abnormal FISH analysis, which means that 97% of sperm will be normal. So it's very difficult to interpret the results and tell the patient that the chance of having a abnormal baby is like X or Y, because we cannot actually communicate properly the effect of high aneuploidy rate on sperm, on the offspring. So FISH analysis, although it has been reported and some people actually rely on these results for counseling and sometimes to offer donor sperm, I do not do like that. I rarely do FISH analysis in my clinic. So what I do quite a lot, investigate sperm DNA fragmentation, because there are so many conditions, external conditions, actually, that could affect the sperm DNA integrity, including varicocele, systemic diseases, infection, environmental exposure, radio frequency, radiation, could be idiopathic, could be exposed lifestyle conditions like smoking, like inadequate diet, heat stress, environmental factors, I mean, even paternal age. These conditions could affect sperm DNA integrity. And you know, as well as I know, based on a huge number of publications in recent years, which actually confirm that low sperm DNA integrity will affect fertilization, even natural fertilization, but also IUI, IVF, and ICSI. So the effect will be dependent on female age and oocyte quality, because some of the DNA defects might be corrected by the oocyte, and then we might have normal embryo development. But if the DNA repair system is not working properly because the oocyte is not as good, and then the DNA damage is so important, and then there's no possibility for the oocyte to repair the DNA abnormality, and then it might result in an abnormal embryo, failed implantation, miscarriage, or even transmission of the defect to offspring, that will increase the risk of childhood cancer, for instance, and some neurological disorders like autism that has been reported to be related to that. Well, the clinical relevance of the DNA damage is much, let's say, more important than previously recognized. It's very common in infertile men and male partners of couples attending our programs. There is it has been associated with reduced fecundability, which means longer time to pregnancy, natural pregnancy, and also recurrent pregnancy loss. And for us working in the IVF clinic, there is reduced reproductive outcomes, both IUI and ART, in patients with sperm DNA damage. And also, as I said, there's a possibility to transfer sperm genetic defects using IVF and ICSI with a potential negative effect in the health of resulting offspring. Well, the DNA tests, I believe you have heard many lectures about the sperm DNA fragmentation tests before. Well, I want to discuss briefly these things with you. We have at least 8 tests, and I provided you some papers in the literature associated with this talk. Please go through some papers there in which I explain in detail the importance of the tests, the guidelines, and also the technical limitations of the testing sperm DNA fragmentation. But I want to emphasize that among the 8 most common tests, tunnel, SCSA, the sperm chromatin dispersion test or the halo test, and the comet assay are the 4 most important assays to analyze sperm DNA fragmentation. So if you have to choose a test, you need to choose among one of these 4 tests listed there. Do not use the tests in the left panel because they are not robust enough to test actually sperm DNA fragmentation. So the DNA fragmentation is important to understand that when we say DNA fragmentation, we might be actually looking at the single strand break, I mean affecting only one strand of the DNA, or double strand breaks. So the single strand break is more, let's say, there is more possibility to be repaired by the oocyte machinery. But by contrast, the double strand breaks are difficult actually to be repaired by the oocyte, and these are more important. So when we test for DNA fragmentation, actually, we don't know if the patient has single or double. Actually, we are assessing the total output, unless we do the COMET assay, because the COMET assay, we can actually run the COMET assay in the neutral and the alkaline COMET assay. They can do together the electrophoresis. And in that case, we might be able to actually appreciate the proportion of double and single strand break. But for the other three tests, actually, we just have the full output, the whole output of the DNA fragmentation without actually knowing exactly if it's single or double strand break. But every time you read a paper and it says sperm DNA fragmentation, we are specifically discussing breaks affecting the DNA. Sperm DNA damage is more broad in terms of things that could affect the DNA. We might have a damaged base, mismatch, intra-strand cross-link, or inter-strand cross-link. These are actually other conditions that could affect the DNA properties, which are not actually evaluated by the sperm DNA fragmentation test. So it's important to understand the limitations of this test. In terms of the conditions actually affecting the DNA, the sperm DNA, the oxidative stress is the most important one. And it has been shown that during epididymis transit and post-ejaculation, it's when the DNA got, let's say, affected by these breaks, and the DNA fragmentation will be actually resulting most often from oxidative stress during sperm transit and post-ejaculation. So oxidative stress, think about that. Why? Well, because if you have a patient with risk conditions, let's say lifestyle factors, varicocele, smoking, infection, leukocytes, because leukocytes makes a lot of reactive oxygen species. Well, it's an opportunity to treat these patients with interventions that could reduce oxidative stress, and eventually it might alleviate sperm DNA fragmentation related to oxidative stress that will have a positive impact in IUI, IVF, and ICSI outcomes. So this is one issue. Also, the sperm DNA damage could come from apoptosis during sperm production in the testicle or during sperm transit in the epididymis. These two conditions are the most actually important ones related to sperm DNA damage, but don't forget that protamination failure, which means deficient replacement of histone to protamines during spermiogenesis, so I mean inside the testicle, could actually cause sperm DNA damage, and it's not related to oxidative stress and apoptosis. So these are the three mechanisms that actually affect sperm DNA damage that you need to keep in mind. Well, the tests I have already mentioned to you in this paper that I shared with you, the clinical utility of sperm DNA fragmentation testing. It's a guideline we published in Translational Andrology and Urology. So you see recommendations based on clinical scenarios. In this guideline, we provide recommendations for testing. So in terms of what kind of specimen should be used for sperm DNA fragmentation testing, processed or neat semen? Well, according to the predictive ability of specimens related to pregnancy outcome, it's important to use the neat semen sample that will provide an overview of the sperm quality in terms of the genetic content. It's important to use a fixed ejaculatory abstinence period before collection of semen. So in our clinic, we use it 2 days, up to 3 days, ejaculatory abstinence, because these are the period we have seen in which the DNA fragmentation could go down. So if you use the same, let's say, abstinence period as recommended by the WHO concerning the semen analysis, up to 7 days, well, in that case, the longer the abstinence period, the higher the sperm DNA fragmentation. Try to avoid that by decreasing the ejaculatory abstinence to 2 to 3 days. That will represent better sperm quality with regards to sperm DNA fragmentation. It's also important to use a protocol which is standardized with quality control. So use a good lab. If you want to implement in-house, you need to do it with proper quality control. And if you use external laboratory, it's important to use a reliable protocol and with quality control as well. And the sperm DNA fragmentation thresholds that you presented according to the test you use will reflect the probability on reproductive outcome. The minimum requirements for sperm DNA fragmentation testing, obviously you need semen, you need a minimum number of sperm, around 1 million per ml or more, and you need at least 30% motility, because you will represent that we have at least 30% viable sperm. Why is that? Because if motility is too low or viability is too low, you will inflate sperm DNA fragmentation results in the wrong direction. Because I mean, if the motility is too low, viability is too low, you see a lot of DNA fragmentation related to sperm death, not actually the proportion of live sperm with the DNA fragmentation might not be as high. So in this condition, when you have motility, very low motility, very low viability, it's important to perform a gradient and then carry out the sperm DNA fragmentation test in the viable or motile fraction. So patients with obviously azoospermia, cryptozoospermia, very low sperm counts, motility, viability, they might not be the ideal candidates for sperm DNA fragmentation testing. We have published quite a lot in this area. This is one of my focus of research. And we have seen that patients, infertility patients, usually they have higher sperm DNA fragmentation values in different infertility etiology. Here you can see leukocytospermia, post-infection chlamydia, testicular cancer, varicocele. When we compare with donors, sperm donors, it's significantly higher the DNA fragmentation results that we have got with these patient categories using this sperm chromatin dispersion test that can be used using the optical microscopy. You can see when sperm has the halo here, you can see the halo, different size sometimes, but you can see the halo, so it means that sperm is intact, no DNA fragmentation. And here you can see sperm with no halo, and then it means that the sperm chromatin is damaged because it has been released, it spread. You cannot see attached to the nucleus. This is again without sperm without a halo. This is called degraded sperm, which is very, let's say, severe sperm DNA fragmentation scenario. If you have the possibility of using the fluorescence microscopy, you see very beautiful pictures like this, in which you can identify easily sperm without the halo here and here, and the sperm with halo. So the fluorescence microscopy is quite also interesting to use for analysis. So we can use the optical microscopy or the fluorescence microscopy. In our clinic, we use most often the optical microscopy for sperm DNA fragmentation using the SCD assay. And the threshold that I like most is the threshold of 30%. When I have 30% and above, we say that we have abnormality in sperm DNA fragmentation results. So between 20 and 30%, it's a gray zone, and below 20%, it's considered within normal range. So what is important to understand is that even when you have conventional semen parameters within the normal range, according to the WHO, in our hands at Androfert, we have 17% patients fitting in this category of normal conventional semen parameters with SCD results higher than 30%. So these patients, they have unexplained infertility we cannot find anything on physical examination, on history, but still we find high DFI, which means that the cause of infertility might be related to sperm DNA damage. When we go for the full, let's say, spectrum of patients we see at Untitled, and then this is the distribution of patients. If I consider the 20% threshold, then I have the gray zone here from 20 to 29, and then the abnormal results from 30 and above, I have about 53% of patients seen at Untitled with sperm DNA fragmentation index 20% or greater. So if I exclude the gray zone, I will have about 25% of my patients with high DFI. So again, this is a referral center for male infertility, but it just stresses the importance of sperm DNA fragmentation for infertility patients. This is why I do think we need to consider ordering sperm DNA fragmentation testing, at least in these 4 different scenarios listed there. The first one is clinical varicocele, palpable varicocele. So in a case, for instance, I have a grade 2 or 3 varicocele with normal conventional semen parameters that we are not sure if we should recommend surgery or not because the conventional semen parameters are normal, or when I have a small grade 1 varicocele with a borderline or just slightly abnormal conventional semen parameters that I'm not sure if the varicocele is actually causing the damage, this is a condition that we should order sperm DNA fragmentation testing, because if test comes abnormal, it will reinforce the importance of varicocele as a contributory factor for sperm DNA fragmentation. In that case, varicocelectomy might help to reduce sperm DNA fragmentation with a positive effect on pregnancy outcomes. The second condition we consider important is unexplained infertility, because I showed to you that patients with normal conventional semen analysis, they might still have difficulties to conceive, and they might have DNA fragmentation as a causative factor. In patients with IUI failure and recurrent pregnancy loss, sperm DNA fragmentation might be the explanatory factor. In case of IVF and ICSI failure, again, there's a possibility that sperm DNA fragmentation is contributing to the negative outcome. And when I have a patient with borderline abnormal or even normal semen parameters with risk factor, for instance, obesity, inadequate lifestyle, smoking, or exposed to environmental factors, and the patient is very reluctant to actually change the lifestyle, I think it's important that we have laboratory confirmation of a DNA defect affecting sperm to reinforce and to convince the patient that they need to change the lifestyle or they will pay the ultimate price. So these are the 4 conditions I believe we should go for sperm DNA fragmentation. I explained about varicocele already. There are some papers I included in the literature. For IUI, there's a strong association between DNA fragmentation and IUI outcome. This is the most recent meta-analysis showing that the risk of pregnancy failure is actually associated, remarkable association with high sperm DNA fragmentation. The most recent systematic review and meta-analysis also showing that sperm DNA fragmentation will have a negative impact in both IVF and ICSI pregnancy outcome. So not only IVF studies, but also ICSI studies showing, let's say, a negative influence of sperm DNA fragmentation. And even when we split the results according to different sperm DNA fragmentation assays, you can see by Tunnel, SCD, Comet, and SCSA, the odds ratio is actually confirming that having high DNA fragmentation actually will have a negative effect on reproductive outcomes of IVF and ICSI. More importantly, when we exclude female infertility factors, the odds ratio becomes even more remarkable. This stresses the importance of the male factor affecting the DNA quality, sperm DNA quality, with impact on the IVF ICSI outcomes. So this is important discussion because contrary to some people who believe that there's nothing to do when we have sperm DNA fragmentation abnormality, I do think that we need, first of all, to identify by ordering the test, to identify the male patients with abnormal sperm DNA fragmentation testing results. Then we need to do a comprehensive male infertility workup, as I presented in the first lesson 2 weeks ago, to identify the underlying conditions that could be associated with sperm DNA fragmentation, including the lifestyle factors like smoking, obesity, occupational toxicants. Let's say the patient could be working in a very hot place or in a place with some pollutants that are known to affect sperm DNA fragmentation. It could be a patient with varicocele, with a genital tract infection, leukocytospermia, diabetes, metabolic syndrome, thyroid disorders, hyperprolactinemia could also increase sperm DNA fragmentation. We could identify and treat these conditions. Treating these conditions could be by varicocelectomy, could by treating the infection with antibiotics, could be by adding oral antioxidant therapy, and I'm including some antioxidants that we need to consider when giving the patients the prescription, and also avoiding these stressors promoting oxidative stress. In some cases, it has been described that follicle stimulating hormone therapy, specifically using recombinant FSH, has been shown to have a positive effect to decrease sperm DNA fragmentation. This is a new information based on very, let's say, recent randomized control trial. And also we can actually go directly to ICSI because there's no point of putting the patient on intrauterine insemination if the sperm DNA fragmentation is too high, or even IVF, conventional IVF. So the best results will be with ICSI. And if ICSI fails, and then we need to consider using testicular sperm rather than ejaculated sperm for this patient category. So here you see that even when we use ICSI, there's a increased risk of miscarriage by using sperm from the ejaculated sperm for ICSI in men with high DF5. So we have two options. Either we go identify the underlying conditions, try to reduce sperm DNA fragmentation, or we need to actually use testicular sperm because it has been shown that testicular sperm has lower DNA fragmentation rates as compared with ejaculated sperm. I will go through these conditions more when we will discuss treatment opportunities, and this I will go in more detail 2 weeks from now. It's going to be lesson 4. So to conclude, now I want to conclude the part of the presentation related to the normal genotype in somatic cells, in which we have sperm abnormalities only. So just remember that the genotype could be normal, but we could still have sperm chromosomal abnormalities, aneuploidies. We can have sperm DNA damage, sperm mitochondrial defects, and sperm epigenetic abnormalities. These conditions are associated with infertility and impaired reproductive outcomes. So testing, most importantly, sperm DNA damage, will provide invaluable information of these genetic sperm conditions. So among the testing available for testing sperm DNA fragmentation, the tunnel assay, SCSA, sperm chromatin dispersion test, and the COMET assays, they are more relevant owing to the association of these testing results and conditions affecting the DNA, in particular, those related to oxidative stress. And the clinical utility of these tests have been confirmed in specific clinical scenarios that, and importantly for us, the test results could guide the clinical management. So it's important to look at these aspects as well. Thank you very much for your attention. Once again, it was a pleasure having the opportunity to discuss with you, and I'm now available for taking some questions if you have some. Thank you. Hello?
Yeah, thank you, sir. Thank you very much for such a elaborated session on genetic evaluation in regards to the male infertility. It's a pleasure to hear you from this, on this rare topic, so elaborated. We have certain questions. We make for anyone who is hearing me, if you want to ask any question to Dr. Sanders, sir, you can put that question in the chat box on the right side bottom box.
So there's a question. Can you hear me? Okay. I can see some questions. Shall I go through them?
Yes, sir, you can go through them.
There's a question here asking about use of recombinant FSH or HCG in men with non-obstructive azoospermia. Well, I think it's better that we discuss this particular condition next week, because next week I will be talking about management of men with azoospermia, and I will go through both obstructive and non-obstructive azoospermia, and I will explain the algorithm that we use for improving the chance of retrieving sperm in men with non-obstructive azoospermia, and I will explain when I use HCG and recombinant FSH. So let's save this one for next week. I will mark that one, and then we can go through. So there's another one here about any role of recombinant HCG in case of severe oligo. Well, this is very controversial because there are not actually randomized controlled trials, good studies suggesting a positive effect of any medication in terms of the reproductive outcomes in patients with severe oligozoospermia. So even if you give medication, or if you give clomiphene citrate, aromatase inhibitors, etc., what we can see is an increase in sperm count, but it not only translates in higher pregnancy rate. So I do think that it might be a role in some cases when we have very low sperm quantity and we are planning to freeze sperm to kind of plan an ICSI cycle. I like to improve somehow the sperm count, and I will consider giving recombinant HCG in patients with low testosterone levels. So if the testosterone levels are below the threshold of 300 nanograms per deciliter, I might consider boosting testosterone production as a means of trying to improve also sperm count. You can give HCG, you can also give clomiphene citrate. You need to monitor the endocrine profile, because if the FSH levels after giving clomiphene citrate, for instance, goes very high, it might be detrimental. So you need to control the endocrine profile, monitoring FSH levels and testosterone levels. But for severe oligospermia, try to see if you have other issues. For instance, varicocele could be an issue that if you have a large varicocele, you might need to discuss with the patient a possibility of treating the condition. You might also check with the patient if there's any issue related to lifestyle, in gonadotoxin exposure, like I presented in the first talk, using some gonadotoxins. Sometimes the patient is using some drugs like antidepressants, inhibitors of the serotonin uptake, for instance. It's a very good antidepressant agent, but could also decrease the sperm count. So try to do the comprehensive male infertility workup to see if you'll be able to identify if the severe oligospermia is related to a condition that you might overcome somehow. And I mean, you might actually decide if you want to give any medication. It will be, if there is no condition associated with the severe oligospermia, it's, let's say, idiopathic, any medication at this point is empirical. So we don't have, let's say, a guideline or a consensus that the medication, including HCG, will be of any value. I do like to boost testosterone production with HCG, specifically with the recombinant HCG, that we'll discuss in more detail next week. So there's another question here, which is, so the patient with sperm DNA fragmentation on the higher side with a grade 1 varicocele, should he be treated for varicocele? I do think so, because when we grade the varicocele, we can grade the varicocele by, let's say, when I put the patient standing and I can see the varicocele, I say this is a grade 3, a large varicocele. If I can't see, but I can feel the varicocele using the physical examination, and then I can say that the patient has a grade 2 varicocele. And if I can't see, I can't feel, but when the patient makes the Valsalva maneuver, so increase the abdominal pressure, I can feel the veins enlarging, this is the grade 1 varicocele presented there. So this is clinical varicocele. And in patient with grade 1 varicocele and high DNA fragmentation, we have evidence that the varicocelectomy will decrease sperm DNA fragmentation. The absolute decrease will be around 8 percentage points. So it means that, let's say, the patient has a DNA fragmentation of 40, or 35, you might decrease sperm DNA fragmentation up to 8 percentage points. So a patient with 40 could become a patient of 32, which is still in the abnormal level, but closer now to, let's say, the more acceptable results. And the important thing about DNA fragmentation, this is not like a discrete abnormal or abnormal result only. These thresholds have to be interpreted with caution, because it means it's continuum. The DNA fragmentation is increasing point by point. The oocyte has an ability to repair the DNA. So you need to see the couple as a whole. If the patient is older and there's other conditions associated with the DNA fragmentation, every improvement you could bring by reducing sperm DNA fragmentation, you might help this couple to succeed because it will be easier for the oocyte to repair the DNA fragmentation if it's lower, and the results in terms of the reproductive outcomes will be more, let's say, impaired in patients with very high DNA fragmentation rather than those with lower DNA fragmentation, although they may still be in the abnormal site. So the next question is related to, let me see. Okay, the question is it likely that sperm retrieval will yield sperm in men with non-obstructive azoospermia with AZFc microdeletion associated with bilateral cryptorchidism? Well, it depends. I think now you are actually bringing a difficult situation because you are bringing the genetic background, which is the AZFc microdeletions, and also bilateral cryptorchidism. Bilateral cryptorchidism per se is a condition that we can find sperm in about 50% of cases. However, it depends on when the cryptorchidism has been treated. So if the orchidopexy has been carried out after age of 2 years old, we know that the older the patient gets the testicles fixed in the scrotum, the lower, let's say, the possibility of having sperm on sperm retrieval. So in this condition, if you have this patient, I would say that the chance of finding sperm by the AZFc condition per se will be 50%. But now the patient has bilateral cryptorchidism. If the orchidopexy has been done below age 2 years old, I would say that the patient still has a good chance of having sperm in about 40% success rate. However, if the cryptorchidism, the orchidopexy has been carried out later on, and then the results will be much lower, but still, you will be able to find sperm in about 20% of cases in which you have the combination of AZFc microdeletion associated with bilateral cryptorchidism. So the counseling of this patient will be different. I would say, well, now you have a condition which aggravated your genetic background explaining your male infertility with AZFc, but still the chances of finding sperm in that case scenario will be around 20%. So we have now a question about the percutaneous epididymal sperm aspiration. If it can lead to fibrosis of epididymis, can we still do in obstructive azoospermia case? Yes, I mean, every time you do a percutaneous epididymal sperm aspiration, you will cause obstruction, you cause fibrosis. Even when you use a very thin needle, you cause some fibrosis. So my suggestion to you is every time you do a percutaneous epididymal sperm aspiration, start in the mid portion of the epididymis, not in the head. Start in the mid portion and see if you can find good sperm, motile sperm with good morphology. If not, and then you move up in towards the direction of the epididymis head, because obviously the higher the puncture, I mean, the higher in terms of going towards the epididymis head, the better sperm quality. But then obviously you will limit your opportunities to do repeat percutaneous epididymal sperm aspiration. So yes, percutaneous epididymal sperm aspiration can lead to fibrosis. And if it happens, it's very easy to overcome the situation by going directly to the testicle, and then you need to do testicular sperm aspiration. And testicular sperm aspiration you can do many times, because the testicle in patients with obstructive azoospermia will have between 600 and 800 seminiferous tubules. And in obstructive azoospermia case, the tubules will be making sperm. So it's not an issue actually to find sperm production. So you can do testicular sperm aspiration today, And 3 months from now, you can repeat it. You can also consider freezing sperm when you do the percutaneous epididymal sperm aspiration to kind of avoid the need to repeat these procedures. Another possibility, and I will discuss that in more detail next week, will be to do the microsurgical epididymal sperm aspiration using the microscope, because in that case, and we are doing quite a lot at Androfert now, the microsurgical epididymal sperm aspiration, it's a condition in which I can collect sperm the way I like to cryopreservation. So in this condition, although it's more, the intervention is bigger because we need to put the patient, let's say, and open the epididymis using the microscope to identify the best epididymis tubule to open and collect the fluid. And then I can move from one tubule to the other, etc. And then I can collect quite a lot of sperm for freezing, making it very easy for the laboratory to actually plan the X cycle with the frozen thaw epididymis sperm, which provides very good results. So percutaneous aspiration can lead to fibrosis, very easy to overcome by testicular sperm aspiration. And you can freeze when you find good sperm, and you can also use the microsurgical approach. So next question will be, can severe astenospermia patients have normal DFI? I think it's unlikely. I think it's unlikely. So if I have a patient with, let's say, severe astenospermia, I'm considering that you are talking about a patient with 70% and more, let's say, sperm with immotile sperm or dead sperm. In that case, you should find abnormal DFI. So, because, I mean, the DFI result will be a combination of live and dead sperm. So it's very unlikely in that case scenario that you have a normal DFI unless the astenospermia is related to a genetic defect affecting the sperm motility. Like if you have a patient with Cartaginer syndrome, for instance, in which you have a ciliary problem affecting actually the microtubules. And in this condition per se, you might find sperm viability of 90%, 100% immotile sperm. And in that particular case, still the DFI could be normal. So with exception of this genetic condition called Cartaginer syndrome, in which is the motility, let's say, abnormality is related to a ciliary problem. Otherwise, you find high DFI related to astenospermia. This is what you should expect. In cases of Cartaginer syndrome, then you need to collect the sperm from the testicle, which is very good. You can collect the sperm from the ejaculate, do hyposmotic swelling test, for instance, and select the viable sperm for ICSI, and it could be also an option for treatment. So the next question is about letrozole, not recommended in a comparison to anastrozole for management of non-obstructive azoospermia. Well, I think both could be recommended. You can use letrozole, you can use anastrozole. There's no study actually saying that one is better than the other. Well, it's depend on the availability. Some people use 2.5 milligrams letrozole for as in the management of men with non-obstructive azoospermia. Our preference in our center is anastrozole, in which we use 1 milligram per day. But the rationale of giving this medication would be to decrease the conversion of testosterone to estradiol. High estradiol could inhibit the pituitary, so affecting the, let's say, this residual spermatogenesis in men with non-obstructive azoospermia. So the rationale of giving this medication will be to avoid losing, let's say, the effect of testosterone. So we, in our clinic, we use anastrozole, as I said, but you could also use letrozole if you have that available, in case you have a testosterone to estradiol ratio below 10. So it means when you have a testosterone to estradiol ratio below 10, it indicates that you have aromatase hyperactivity, or it also means that the testosterone is being converted to estradiol by the aromatase. And in order to avoid that, you can add this medication. Well, I mean, again, you can use both. So in that case, should be 2.5 milligrams. You can use 2.5 milligrams per day, or you can use 2.5 milligrams every other day. The only important thing is that you need to monitor. Just have a look at the estradiol levels and testosterone levels after starting the medication, because if the estradiol levels goes very low, actually you might have some side effects, and then you don't need actually to use the dose you started giving. So you might tailor the dosage. And then for the letrozole, what I have been recommending my colleagues who do not have the anastrozole available is actually to kind of give letrozole every other day or every 2 other days. They're very easy to monitor because you just monitor using total testosterone and estradiol levels. When you see that the testosterone to estradiol ratio now is normal, I mean, above 10, and the estradiol levels are low, you can tailor the dosage. But start with 2.5 and then see how it goes. Well, I think so. I mean, the serum FSH should rise after unilateral orchidectomy. So, but the rise won't be so remarkable. It depends on, again, the genetic background of this patient. Because if the patient, let's say, if the patient had an excellent genetic background in which both testicles were normal in size with a very good sperm output, and then you just take one testicle out, well, the remaining testicle could actually be in a position that could provide a good sperm output, and the negative feedback by inhibin B to the pituitary will be controlled, and you don't see a remarkable FSH rise. So you need to see case by case, but usually you will have some loss of a testicular reserve by doing orchidectomy, and you shall have increasing FSH. The same as AMH in the ovaries. When you take one ovary out, usually we see there's a decrease in AMH levels. And FSH also, it's indirect measurement of the testicular reserve, but you should expect a FSH rise. But FSH rise, remember the first talk I gave you last week. When we have 7.6, the 7.6 and above, we can consider high FSH. You don't need to go for the very high above 13, 15. So if the patient after unilateral orchidectomy is now having 8.5 FSH levels, and it was before 3.5, although the patient is still according to the reference range in the normal levels, well, there's a increasing FSH rise in that particular condition. So the other one in terms of, there's another question here in terms of the dose of letrozole that I have already responded. Any other question?
Yeah, I think no more questions are there now. It's any more questions from the fellows, please. I think it's done, sir. No more questions are there now. Hopefully, it's everybody's exhausted after this much of elaborated lecture, and I'm very grateful that we are learning the management of a male infertility in a proper fashion. By first lesson was about evaluation, now about the genetic assessment, and then later on the next two will be on about the management. And I feel we all will be enriched in the management of male infertility. So I'm very great to you, sir, that you have taken up these lectures for us.
So thank you very much for your attention, for your participation, and thank you for the opportunity to speak to you again. So looking forward to seeing you next week.
Yes, sir. See you on 9th September.
Thank you very much. Goodbye.
Thank you, sir. Thank you. Bye-bye, sir. This is the one direct one.